Hello. Today I'm going to talk about prophylactic bile treatments in hematopoietic stem cell transplant patients. First off, what is hematopoietic stem cell transplantation? Well, HSCT is a treatment for patients with hematologic malignancy, such as leukemia. It is also referred to as bone marrow transplant, short form BMT. This process involves myeloablation, which is the removal of all hematopoietic stem cells by destroying diseased bone marrow, followed by a transplant of hematopoietic stem cells in the form of new bone marrow. It is important to note that these immune cells migrate to the bone marrow because it's the site of hematopoiesis. Hematopoiesis is the process by which erythrocytes and leukocytes form and develop, so the lack of bone marrow results in the reduction in hematopoietic stem cells. This lack can lead to a state of neutropenia, which is defined as a state of decreased neutrophil count. Thus, the immune system has become compromised. This schema depicts the way that hematopoietic stem cells are activated and migrate to the bone marrow to develop into immune cells. The HSC cell activation is initiated by binding chemokine receptor type 4, expressed on their surface, to the stromal cell-derived factor 1. These activated HSCs attach onto the bone marrow endothelial barrier, facilitated by the vascular adhesion molecule 1 and the intracellular adhesion molecule 1. Then, these HSCs cross the endothelial barrier into the bone marrow. We need to discuss how HSCT affects the immune system. First, transplanted cells take time to develop into functioning immune cells. It can take days to weeks for the new immune cells to begin to develop, then migrate, as shown previously, and mature in the transplanted bone marrow. Second, not all immune cells recover at the same rate. McKay and al. Found that the first types of cells to recover are the neutrophils, monocytes, and NK cells, then platelets and red blood cells, followed lastly by B and T cells. So these post-HSCT patients spend a few days to weeks with extremely weak immune systems, leaving the patients immunocompromised. It was observed that in post-HSCT patients, certain viruses, such as the cytomegalovirus, which is a relatively harmless virus in healthy individuals, can be life-threatening. So why are post-HSCT patients susceptible to viral infections? Well, as explained earlier, post-HSCT patients are lacking mature immune cells. This means that a weakened immune system, in other words, an immunocompromised person, has an enhanced vulnerability to viral infections since they do not have the cells to resist the infection. To understand this better, let's take a look at an example of a specific immunological feature that typically protects the body from viral infection development. Normally, a virus must typically overcome physical, chemical, and cellular barriers, such as the epithelial cell barrier, alpha defensins, and sentinel cells, to create an infection. An example of a sentinel cell is a mast cell, which produces histamines and leukotrienes to prepare the local region for immune cell infiltration. However, post-HSCT patients do not have lots of mature sentinel cells. Also, C5a, a complement pathway component, is typically elevated in viral infections as it signals for the recruitment and activation of neutrophils, an essential immune cell in the inflammatory immune response. But immunocompromised patients have decreased neutrophil levels due to being in a state of neutropenia, so the cellular barrier is non-existent. Hence why the patient is susceptible to viral infections during the 50 to 70 days it starts to produce mature immune cells. Cytomegalovirus, short form CMV, is a prominent concern. CMV is a common opportunistic virus that has infected approximately 70 to 80% of the population, but is typically in a state of inactivity. Although not alarming in healthy individuals, CMV can progress into end-stage organ diseases such as pneumonia, hepatitis, and encephalitis in those who have recently undergone HSCT. In addition, about 75% of patients infected with the inert virus experience CMV reactivation. Thus, opportunistic viruses can significantly affect immunocompromised individuals, such as post-HSCT patients. So to summarize, post-infection treatments for opportunistic viral infections act too late in the virus development for post-HSCT patients due to the reactivation and the decreased immune system.
Since reactivation is a primary concern, post-infection treatments for opportunistic viral infections act too late in the virus development for post-HSCT patients. Therefore, preventative treatments should be examined. These treatments consist of current procedures, including vaccination, T-cell transplants, as well as some theoretical ideas, such as the combination of vaccination and virus-specific monoclonal antibodies, and the combination of gene therapy and T-cell transplants. First, vaccines prime the immune system. Typically, an effective vaccine primes the immune system with memory T and B cells by presenting small immunologic components of the virus. PRRs recognize the foreign viral components on tissue-resident cells, which activate the local acute inflammatory response. Then, pro-inflammatory cytokines are produced and secreted by activated immune cells that induce downstream effects. However, the problem with HSCT patients is that due to the myeloablation process, post-HSCT patients lack most of the immune cells involved in this process. Vaccines also involve the adaptive immunity. The viral markers are recognized by PRRs, then natural killer cells rush to the site of infection to lyse infected cells. The viral particles remaining are phagocytosed by dendritic cells, which load antigens onto MHC2 molecules and migrate to the lymph nodes. Here, dendritic cells present antigens to follicular T helper cells, a subset of CD4 T cells responsible for B cell differentiation, into plasma and memory B cells. Plasma B cells produce antibodies and neutralize the pathogen. Essentially, memory B cells are what provide immunity for future infections as they differentiate into plasma B cells when exposed to pathogens and can persist in the absence of an infection. Vaccination, both pre or post-transplantation, has shown to be effective in protection against viral infection in clinical studies. Pre-transplant vaccinations have been shown to decrease the duration and reoccurrence of viral episodes by increasing humoral response, even in the presence of an immunocompromised immune cell, for example, T cell suppression. One limitation of this treatment is that the success of pre-transplantation and vaccination depends on patients' immune system to produce functional antibodies prior to vaccination. Thus, immunocompromised persons would produce less effective responses. In contrast, post-transplantation vaccines decrease the incidence of viral infections over a 21-month period. CMV vaccination can be administered 50 to 70 days after HSCT, which allows the patient's immune system to recover and antibodies to be produced. However, the patient's immune system is still unable to capture the antigen and produce memory cells during the 50 to 70-day post-HSCT period. So a second dose can be administered 1 to 2 months later.
A third intervention is adaptive T cell therapy. As trialed clinically, T helper cells, Th1 cells, were cultivated in the laboratory for each patient and educated to target the adenovirus, which is another prominent virus causing disease and fatalities. The short form is ADV. These educated T cells generated antigen-specific T cell activity. Then, a T cell transplantation was performed with these Th1 cells. They found that post-HSCT patients had antiviral immunity to adenovirus for approximately 6 months. Figure 2 shows that overall the degree of viremia decreased and the clearance of viremia increased with days post-T cell transfer. The procedure resulted in strengthened immune systems, specifically against adenovirus. A limitation of this treatment is the specificity of the antigen target, as educated T cells trialed were only capable of targeting one virus, ADV. However, future clinical trials could optimize this technique by creating a batch of T cells to target a variety of common post-HSCT disease-causing viruses.
Monoclonal antibodies. This is a combination treatment involving monoclonal antibody injections and vaccinations. Vaccinations are effective in preventing viral infections, but a limitation is that they can only be used 50 to 70 days after HSCT. We suggest that the patient gets treated with CMV-specific monoclonal antibodies during this period. Monoclonal antibodies are useful since they can be produced in vitro. The treatment involves 4 injections over the course of an 8-week period, followed by the vaccine around the 50-day mark. This is why the patient receives a half dose of monoclonal antibodies every 2 weeks, since they have shown to have a half-life of 7 to 14 days. Note that this treatment is currently theoretical and therefore would require clinical studies to test its effectiveness. Also, the monoclonal antibodies could reduce the efficacy of the vaccine if vaccinated too early. Another limitation to this treatment is that it is virus-specific and would not protect the patient against other viral agents during the initial 50-day period. Gene therapy. This is a combination treatment that involves gene therapy and T-cell progenitor transplantation. The aim is to increase the expression of the lymphotoxin beta receptors, LBR, as they are responsible for increasing the uptake of T-cell progenitors in the thymus. The thymus is the site for T-cell maturation, where T-cell progenitors develop into CD4 positive and CD8 positive cells. These mature T cells play a major role in the immune response to infections. We suggest that the gene of interest, the LBR gene, be treated using an adenovirus vector due to its large size. Before LBR can be introduced into the ADV vector, we must control its replication. From the genome, we would remove the E1A gene, which is involved in viral replication. Then, the LBR gene will be inserted as a plasmid into the virus. Once inserted, the introduced viral vector would act in the thymus to upregulate the LBR receptor. This treatment would increase the expression of LBR and transplanted T-cell progenitors into the patient, which would increase the uptake of T cells in the thymus, leading to an increased rate of T-cell maturation. A benefit of this treatment is that it is not virus-specific and would provide protection against various viral agents. A limitation is the cost and time it would take to cultivate a vector.
Here are the references. Thank you.